Pediatrics Part 2. First topic what we are learning is painful limb. It is an atraumatic painful limp what the patient has come in with. He'll be limping because of the pain and it is not because of the trauma. What are the differential diagnoses what we need to really think of? Depending on the age group, you can classify the diagnosis. So whenever the stem of the question, always have a closer look at the age. If the age group is between 1 and 3, the differential diagnosis will be either developmental hip dysplasia, toddler's fractures, or transient synovitis. Transient synovitis can also be seen in age group around 4 to 10, but mainly in the toddlers, what we'll be seeing the transient synovitis. Most of the time, it is between 3 to 5 years, it is commonly seen, but can be seen anywhere between 2 or 1 year also, it can be seen. When they start walking, basically, you can see and transient synovitis at that point of time, toddlers age group. Perthes disease, again, it is common usually around 7, 8, 9, 10 years of age group. Leukemias also becomes common in this age group. In adolescent, the main differential diagnosis for you is slipped upper femoral epiphysis. You need to remember there are other differential diagnoses also which can be appear in any age group. The most important one is septic arthritis. So whenever a child comes to the emergency department with an painful limb, it is an septic arthritis for you until and unless proven otherwise. We'll be learning how to go about it. Osteomyelitis, we have learned previously, it is something which is there for a longer duration, a severe infection, which is not resolving even with oral antibiotic. Then you start thinking of an osteomyelitis. X-ray will be helpful in this diagnosis. Rest of the things we will be studying or we might have studied somewhere or the other place. But these are the main things what you need to remember from exam point of view. Let us see each one of this. The first thing what we are looking into it is the septic arthritis. Septic arthritis is one of the important differential diagnoses. It should be one of the topmost differential diagnoses when a kid comes with a limp. So how to go about it? In that, you need to go and look into the Koch's criteria. In Koch's criteria, you'll be looking for, is the kid not weight bearing on the affected limb? Is the kid having a temperature which is more than 38.5 degrees Celsius? Is the ESR more than 40? Is the WBC counts more than 12,000? If any two of this is present, possibility of this kid having an septic arthritis is 40%. It's as high as 40%. So it is enough for you to suspect an septic arthritis if only two of the points what's mentioned here is present. It's 40%. Then you need to go ahead and further evaluate. What evaluation you will be doing? You'll be doing an synovial fluid analysis. If the synovial fluid analysis is suggestive of an infection, then you'll start with antibiotics. Usually IV antibiotics will be required, plus you will admit this patient. So remember that whenever they mention a limp, you look for at least two of this following is present or not. Not weight bearing is nothing but a limp itself. Along with it, patient currently has the fever. Currently should be having the fever, not that previously he used to have and he has recovered with it. A week back, he had some fever, cough, cold. Now he doesn't have any fever. That doesn't mean that the patient is having a temperature of 38.5 degrees Celsius. Be aware of that point. Along with it, you need to get an ESR and WBC count to help to differentiate it. Irritable hip, also known as transient synovitis, they are one and the same. Do not get confused. It is usually seen in the age group of 3 to 5 years of age group. They come in with an painful hip or an limp in a child. Okay, most of the time the child might not be speaking or might not be communicating as an adult. So parents must have observed that the kid is limping. When the kid is limping, you need to take a thorough history. There will be a viral illness, a predisposing viral illness will be there. So it is a viral infection what the patient is having. That's why it is known as synovitis. Itis is basically an inflammation. You need to always rule out septic arthritis. How do you rule out? You do an Koch's criteria. See the scoring. If the score is 2, then you need to do an synovial fluid. If the score is 1, then the chances of this patient having a septic arthritis is only 3%. At that point of time, you need not think about septic arthritis and go ahead with an irritable hip or transient synovitis or some other differential diagnosis depending on the age group what they are presented and the other symptoms what they are presented with. First thing, developmental dysplasia of the hip. It is usually seen in the newborns. In the newborns itself, a screening is done by the pediatrician for a developmental dysplasia of the hip itself. How is the screening done? By doing an Barlow test. What is it about? What they do is they do an adduction, adduction, where the limbs or the hips go away from the midline and they pull. While they do this, hips gets dislocated. To relocate it back, they do an abduction followed by they'll be pushing the hip backwards and it will relocate back. This basically is suggestive of developmental dysplasia of the hip, developmental. So it is something which is at the birth itself. It is very commonly seen in girls with an breech presentation. There is an family tendency here. You cannot do anything in the emergency department. If they present with it, you will be just referring. Unlikely to be tested in the exam because it is usually screened by the pediatrician at the time of the birth itself. Perthes disease, also known as lack of Perthes disease, it means one and the same. There is no differentiating factor. What happens here? Here is avascular necrosis of the femoral head. How does the avascular necrosis? It's because of the reduced blood supply to the epiphysis of the femoral head results in avascular necrosis. That is known as Perthes disease. The age group is important, 3 to 10 years, but mainly it will be seen around 7, 8, 9, 10. This is the age group what you need to look out for in the stem of the question. This is not an infection. This is an reduced blood supply. So if you get the inflammatory markers like an ESR, CRP, WBC count, all this will be in the normal range. That will help you to differentiate from an septic arthritis. Always get an X-ray done if someone comes with the limp in this age group because you are always thinking of an Perthes disease X-ray as an classical findings. What are the classical findings you'll be seeing on an X-ray? This is an avascular necrosis. Because of the avascular necrosis, there is death of the bone. That means the joint space, what you're seeing here, this is the normal side, this is the abnormal side. In abnormal side, you can see the joint space has increased. Along with the joint space has increased, few sclerotic changes you can see, few rarefaction you can see. Rarefaction is basically a destruction of the bone and it appears like a cyst and it appears darker on an X-ray. These are the classical features what you'll be seeing on the X-ray. This is because of avascular necrosis. What is the treatment? You cannot do anything for an avascular necrosis in the emergency department. You need to involve the orthopedics. Slipped upper femoral epiphysis is usually seen in adolescents. So around 12 to 16 years of age group is the one where you need to suspect it might be a slipped upper femoral epiphysis. The classical presentation will be either the obese adult where the genitals are underdeveloped or a tall thin individual where the sexual genitals are basically normally developed or the genitals are normal here. So tall thin individual where the genitals are normal or an obese individual where the genitals are underdeveloped. These are the two different types of presentations they can come in with. To make a diagnosis, you will get an AP view and lateral X-ray of an hip. If required, you will be getting a frog leg. Frog leg is the preferred one. It's a special view what we'll be having. This is the frog leg view where where knee is flexed and hip is abducted in this manner what is shown here, similar to a frog leg. That's why it is known as frog leg view. What you basically are looking out for. Basically what you're looking out for is this. This is known as Kellen's line. It is also known as Tritovan sign. Kellen's line, this line which is drawn is known as Kellen line. Tritovan sign is, if it is positive, then we call it as Tritovan sign is positive. So what is Kellen's line? Kellen's line is a line which is drawn below the ossifying center of greater trochanter. So this is the greater trochanter. Below this line is drawn. If you draw a straight line, it should bisect the femoral head. Okay, as you see here, pictorially, it should bisect it. If it doesn't bisect as it's shown here or just touches it a little bit, then you need to suspect it is a slipped upper femoral epiphysis. If it doesn't bisect, then Tritovan sign is positive. So this sign is positive. This is the diagnostic for you. Then you will be referring for the orthopedics. Orthopedics will take care of this one. So how it appears on an X-ray, let's have a look at an X-ray. So it is in Killian's line, which is drawn just below the greater trochanter ossifying center, and it is not bisecting the head as you see here. This is known as Tritovan sign, which is very much suggestive of a slipped upper femoral epiphysis. It can be bilateral. So don't get confused if both sides the same finding is present. For example, someone is presented with a right-sided limp. And when you get an X-ray done, the findings are bilateral. It can be bilateral. It is very commonly seen bilateral. So do not get worried. Slater-Harris injuries. This is basically seen only in the pediatric age group because epiphyseal centers are seen in the pediatric age group. So a maturing bone will have an epiphysis, physis, and a metaphysis. This is known as metaphysis. The green color what you're seeing here, this green color what you're seeing is known as physis or growth plate, and this is known as epiphysis. So bone is growing. The growth plate grows as you grow or as you get older and older. It's tends to grow. So depending on the fractures of the metaphysis and the epiphysis, what is involved, it is classified into 5 classifications, which can be remembered with the mnemonic of Slater itself. So each one of this will be seeing now. First one is yes. Slater mnemonic I'm going for. Slater, the name itself, first it starts with yes. Yes is straight across. So what happens straight across? What do you mean by straight across here? The epiphysis is separated from the metaphysis here. So the growth plate kinds of gets enlarged, or it is kind of pulled away from each other. So on an X-ray, it might appear normal. It is very difficult to appreciate what's the gap here. Is it a growth plate or it is not growth plate? Is it pulled or not? It is very difficult to pick it up on an X-ray. So most of the time, X-ray might be normal in type 1 Slater's classification. Type 2, above. Above means the metaphysis, a small chunk of the metaphysis is separated along with the epiphysis. That's why above part, above is always metaphysis. So a chunk of metaphysis is separated with the epiphysis. This is known as type 2. Type 3 is lower. Only there is a fracture of the lower part. Epiphyseal fracture is present. Type 4 is through. Through means epiphysis as well as metaphysis. There is through and through fracture. Both fracture pieces are present. One is of metaphysis, another one is of epiphysis. This is known as type 4 lattice classification. Type 5. In type 5, there is crushed. What has happened? It has gone upwards and this has gone downwards. That metaphysis and epiphysis has crushed each other. There is erase of growth factor. So E or C, you can remember it as crush or an erase of the growth factor. Again, this is difficult to pick it up. X-ray might appear normal. So you should be aware how to pick it up on an X-ray. You should also be aware of the terminologies, that is the wordings also how it is described, because they have tested previously in wordings and they have tested previously by giving an X-ray. So you should be aware of both the findings if they have given. Let's see the X-rays so that there shouldn't be any confusion. This, you cannot pick it up properly. In this X-ray, what you can see, this is the metaphysis. This is the epiphysis. There is a chunk of metaphysis has separated along with the epiphysis. That's why it is known as type 2 Slater-Harris classification or fracture. Here, what has happened? It has gone through and through. A metaphyseal fracture is here. The epiphyseal fracture is here. So it is through and through. It is known as type 4. Type 3, what has happened? Only the lower part, that is the epiphyseal fracture, is seen. Metaphysis is still intact. This is known as type 3 Slater-Harris classification or a fracture. This is a type 1. You can see here, hardly you can pick it up anything. The gap has increased. Here they say the gap has increased. It's very difficult to pick it up, or X-rays appears usually normal. What about this? This is a type 2. Why do I say type 2? This is the epiphysis. Along with the epiphysis, a metaphyseal chunk has come out. This is known as above. Type 2 is above. So above is metaphysis. A chunk of metaphysis has come along with the epiphysis. That's why it is known as type 2. What about this one? Only the epiphyseal fracture end is present. So it is below. Below is nothing but type 3. So you should be able to pick up on an X-ray, as well as you need to be aware of the wordings. Both are very important from exam. Osteochondritis is a group of disorders that affects the epiphysis. A generic term as known as osteochondritis. Most common osteochondritis, what you see, is known as Osgood-Schlatters disease. Now, what happens here? We are aware that the patellar tendon runs from the patella and gets inserted over the tibial tuberosity. What happens? Recurrent use of the knee. For example, you're playing football where you kind of flex and extend your knee very frequently to kick the football. What will happen? Eventually, due to the assault here, due to the contraction and relaxation of this tendon, this will cause fracture of the sorry. This will cause the fracture of the tibial tuberosity. This is known as Osgood-Schlatters disease. There will be no obvious trauma. They won't have fallen down on the knee. They usually say, I was playing and the pain started, and the pain is getting worse over the days. That is the classical presentation. A same thing can happen. For example, athlete, for example, a marathon runner or a sprint runner, where Achilles tendon gets attached or inserted over is the calcaneum bone. So recurrent use of this Achilles tendon, usually during running, can result in Serves disease. This is the similar to that of the osgood disease. What we do an symptomatic treatment, ask them to follow up with the orthopedics. Nothing much is done in the emergency department. It is exclusively seen in pediatric age group where it is still getting ossified. These are the ossifying centers. Ossifying centers gets affected. These ossifying centers are nothing but epiphysis gets affected. So if it is an epiphyseal disorder, what you're seeing, so it has to be seen only in the pediatric age group. So see in the pediatric age group, there is an avulsion fracture of the tibial tuberosity. Then you are suspecting an Osgood-Schlatters disease. Direct trauma to the tibial tuberosity will not be there. It is just the recurrent use of the joint, what you need to look out for in the history. Pediatric elbow is very important. There are different ossifying centers what you need to be aware of. You remember these different ossifying centers by a mnemonic known as critol. Why is it important to remember in a sequence? It is important to remember in a sequence because if, for example, this appears, internal epicondyle appears, radial head and capitulum should be there. If cochlear is present, trochlear along with an internal epicondyle, along with an radial head, along with an capitulum should be there. So the later one, if it appears before that, all the ossifying centers should be there in their respective positions. If they are not there, then there is an avulsion of that ossifying center. So you need to be aware where are these ossifying centers, when do they appear in a sequential manner. To remember in a sequential manner, you can remember the mnemonic critol. It is easier way to remember mnemonic as critol, where C stands for capitulum, R stands for radial head, I stands for internal epicondyle, T stands for trochlea, O stands for olecranon, L stands for lateral epicondyle, also known as external epicondyle. Each one of these ossifying centers appears at an odd age. Okay, so it starts with 1, 3, 5, 7, 9, 11. So all of these are odd numbers. So easy to remember the odd numbers. So now coming to the ossifying centers. How to pick up this ossifying centers? Don't go with a mnemonic as in critol while looking at the X-ray. You might get confused. Some people even get confused with the medial side and the lateral side. So easier way to pick it up is first pick up the radial head. It's easy to pick up a radial head. So you know this is the radial head what you're having. Right above the radial head is the capitulum. Right above the capitulum is the lateral epicondyle. Capitulum, adjacent to the capitulum is the trochlear what you are having. Above the trochlear is the internal epicondyle. If you remember in this manner, it is easier to pick up. Olecranon process is only seen on the lateral view. It is difficult to pick it up on an AP view. Only can be seen on a lateral view. Let us take an example, a classical example, very frequently tested in the exam and frequently comes to your regular practice also. Again, we'll use the same thing. We know this is a radial head. Right above the radial head, what we have? Capitulum. Right above the capitulum, what you have? Lateral epicondyle. Just adjacent to the capitulum, what we'll be having? Trochlea. Above the trochlea is supposed to have a medial epicondyle. So if trochlea is present, medial epicondyle should be there. Because if we go through a mnemonic of critol, if trochlea is present, medial epicondyle should be present. What has happened? Medial epicondyle here is absent. What has happened to the medial epicondyle? It has avulsed and it has gone here. It is very commonly seen in violent contraction of violent contractions of the forearm muscles. Flexion, all the flexors gets attached to the medial epicondyle. It is an ossifying center in a pediatric age group. Violent contraction of this one will result in the avulsion fracture. If this is an avulsion, what has happened? So this is the medial epicondyle which is present. You need to refer to the orthopedics so that they can take care of this one. It requires an referral. It needs to be admitted, needs and surgical reduction of this ossifying center back to its original position. Fat pad signs. As we are aware from the adult itself, fat pad signs are commonly seen. Whenever there is a fracture, there is some amount of fat which is released from the bone marrow, gets deposited around the joints. So it is an indirect indication that there is a fracture. But most of the time, anterior fat pad sign is normal finding. It's not because of a fracture. There's some amount of fat posteriorly also because of presence of olecranon fossa which is present posteriorly. It is not seen on an X-ray. If it is picked up on an X-ray at the posterior fat sign, it is always pathological. Remember that posterior fat pad sign is always pathological. If there is an obvious fracture line, you know that is a fracture which is causing the fat pad sign. If there is no obvious fracture line is present, suspect an radial head fracture or radial head fracture in an adult and supracondylar fracture in a pediatric age group whenever there is a posterior fat pad sign. Anterior fat pad sign can be a normal finding. Do not depend on the anterior fat pad sign. Pulled elbow. What happens during the pulled elbow? The radial head is located inside a ligament known as annular ligament. When the radial head comes out of this annular ligament, slight subluxation we call it, that is slight dislocation from the annular ligament because of the tear of this ligament, annular ligament. They usually presents with a very classical history. Because of the presence of the classical history, we do not get an X-ray done. We do not, after reduction also, we do not get a check X-ray also done. So how do you manage this, or what is the classical history? The classical history is, as the name suggests, it's a pulled elbow. Usually what happens in a toddler, they see a toy or something in the shop and they kind of starts running towards it. Mother or father pulls the kid towards them by holding the hand as shown here. That's why the name is pulled elbow. This causes dislocation of the radial head from the annular ligament. Usually it is a partial dislocation, hence it is known as subluxation. And they present to the emergency department saying that kid is not using that particular limb. For example, right upper limb, the kid is not using at all. It is in pain. It might be crying in the pain. So what you will be doing, you will be taking the history. Once you have the classical history, you will try to reduce it. How you will try to reduce it? You will flex the elbow to the 90 degrees and supinate. When the palm comes over the palm is towards the roof side, that is known as supination. So this position is supination. You supinate. Usually get and click sound, then you completely flex the elbow. If you're able to completely flex the elbow and the kid's fingers touches the same shoulder side, then it is reduced. Then you are not discharging immediately. What you do is you ask the mom to take the kid to the play area, wait for some time till the kid starts using their arm. After reduction, the pain would have come drastically. The pain could have come down drastically. And the kid will start using their limb after a few minutes when they realize there is no more pain. Sometimes if this method is failed, what we do is we hyperpronate. Pronation, hyperpronate, we do it. And again, you flex it. You do not get an X-ray before or after. No fracture clinic follow-up is required. At the time of the discharge, you will be explaining to the mom what is the finding exactly, what is the finding, what have you done, and how to prevent it. So basically, do not pull holding the kid's arm. It might result in one more dislocation. So you will explain them. If at all, if it recurs again, they should always come back to the emergency department. What if you have done this method, everything is done, but the still kit is not using? If the still kit is having pain, that means there must be something else. You have misdiagnosed it. There might be underlying fracture. At that point of time, you might have to get an X-ray done. Supracondylar fractures are very commonly seen in pediatric age group. That's why we are discussing in the pediatric age group. There might be an obvious fracture line, easy to diagnose as a supracondylar fracture. So these are the condyles. Supra means above. Above that, there is a fracture line. So it is known as supracondylar fracture. But sometimes there may not be an obvious fracture line. At that point of time, how to make a diagnosis? We draw a line which is just anterior to the anterior part of the cortex of the humerus. What I'm drawing is just a line, straight line, which is drawn at the anterior surface of the humerus. That's why it is known as anterior humeral line. This line should bisect by 1/3 of the capitulum. Anteriorly, it should be 1/3. At least 1/3, it might be more than 1/3. If it is not bisecting capitulum by at least 1/3, then you need to suspect it has to be a supracondylar fracture. These fractures are classified into 3 types. It is known as Gartland's classification. In type 1, what you see is both the anterior cortex and the posterior cortex are not dislocated. They are in the same line, in the same curvature. They are not dislocated. Here, what you can see here is the anterior part of the cortex is dislocated. They are not in the same alignment at all. But the posterior one, still there is some attachment is preserved in type 2. In type 3, there is no relation between the anterior and posterior cortex. Type 3 definitely requires surgery. Type 1 can be managed conservatively by placing the patient on an above elbow back slap and referring them to the fracture clinic. Usually surgery is not required. Type 2 is tricky. That's why we involve the orthopedic, take their opinion what needs to be done. So orthopedic will come down, assess the X-ray, assess the kit, and take a call whether we need to admit and operate on this one, or can we discharge them and follow up in the fracture clinic. That decision is left to the orthopedic surgeons. Again, it's the same thing what I'm explained here with an X-rays here. This is the type 3 what you are having. This is the type 2 where the anterior cortex, there is a breach in the anterior cortex, but the posterior cortex is still intact. This is where you cannot see both anterior and posterior cortex are still intact. But what you can do is you can draw an anterior humeral line. Anterior humeral line, you can see it is not bisecting by 1/3. That is basically is suggestive of a diagnosis. The other way around to put it across is you can see the black color behind this is suggestive of an posterior fat pad. Posterior fat pad in a pediatric age group, we are always suspecting a supracondylar fracture. That is another way to suspect a supracondylar fracture. Most commonly injured nerve or an artery, if you ask me, it is the brachial artery which gets injured in a supracondylar fractures. Radiocapitular line, which we had learned in the adult also, now we are learning in the pediatric also, because in pediatric age group also you can see this. We are drawing a line from the middle of the shaft of the radius, and it should bisect the capitulum. This is the capitulum by 50 by 50. So 50% above and 50% below it should be. If it is not, then you are suspecting an radial head dislocation. This is known as radiocapitular line, used to make a diagnosis of radial head dislocation. It can be only drawn in a lateral view. Dislocated elbow, what we have studied previously, holds good in the adult and in the pediatric age group. There are no changes. Most of the time, it is a posterior dislocation. The commonly injured nerve is the ulnar nerve. This is the classical finding. You can see the olecranon fossa is completely empty. There are no condyles, which are basically in communication with the olecranon process here. So this is a classical dislocation elbow. What you're having, you try to reduce in the emergency department and place them on an above elbow back slap. If fail to reduce it, then you need to refer to the orthopedician so that they can reduce it in the operation theater. Either you are successful or unsuccessful, you need to involve the orthopedics and admit all the patients. We do not discharge them because there is chances of significant swelling which can develop, can result in compartment syndrome. So we cannot take a chance. That's why we admit all these cases. Toddler's fracture. As the name suggests, it is commonly seen in the toddler's age group. What happens in the toddler's age group? In toddler's age group, they have just started to learn. This is the early age where they are just from the crawling, they are moved to standing up and started to walk. When they walk, they might not be placing their limb in an proper appropriate positions like an adult. They might place the limb in an awkward position, resulting in an awkward stress over the tibia. This can result in a spiral fracture of the lower half of the tibia. It's a spiral fracture what you're seeing here. Spiral means spiral like this fracture. So this is a curved fracture which is present. That's why it is known as a spiral fracture. A spiral fracture seen, this is known as toddler fracture. What we do if it is not seen on the X-ray, because most of the time initial X-ray you see, it will be normal. At that point of time, you ask them to come back after 10 days to repeat an X-ray. Once it is confirmed, then you will be putting them on a long leg plaster and refer them to the orthopedic. That is the fracture clinic, what you will be referring them to. Tilloch's fracture is nothing but it's a new name or a special name given for an Slater-Harris type 3 fracture of an distal tibia. This is the distal tibia what you're having. You can see only the epiphyseal part has been fractured. Okay, this is suggestive of an Slater-Harris type 3 fractures. When it is involves the distal part of the tibia, then it is known as Tilloch's fracture. Just refer to the orthopedics, nothing much needs to be done. You can place them on an above knee back slap. This is the same X-ray which is taken. It is little bit difficult to pick it up because there is an overlying fibula which is present. On a CT scan, which is seen in the cut form, it is clearly picked up. Yes, suspecting, because here you can see this one, the cortex, there is a breach, and this is the part which is there. You're suspecting, that's why they went ahead and got a CT scan done, which is clear-cutly suggestive of a Slater-Harris type 3 fracture of the distal tibia. So these are the various lines what you need to be aware of and which is important, can be tested in the examinations. For example, Bohr's angle used for calcaneum fractures, 3 to 1 sign used for slipped upper femoral epiphysis. Radius, lunate, and capitate line, they should be in alignment. Otherwise, it can be in lunate or perilunate dislocations can be seen. Radiocapitular line, we read it is for the radial head dislocation. Humeral capitulum angle or anterior humeral line, both are for supracondylar fractures. Sorry, metatarsal alignment with the cuneiform is very important. Again, Lisfranc's fracture. This I have clubbed with the adult and as well as the pediatric. So you remember all the fracture lines and which fracture are we looking out for. Green stick fractures. Green stick fractures only seen in pediatric age group because the bone is quite flexible here. Okay, there is only cortical breach on the only one side, not on the both sides what you're having. Green stick, it's a green stick. If you take a green stick and you try to break it, it doesn't break completely. It only breaks at one side, another side is still intact. That's why the name has come as a green stick fracture. Similar thing happens here also. You can see this cortex is involved, but there is a breach in this cortex here. Same thing happens here. This is different from the buccal fracture. That's why I put up here X-ray. In buccal fracture, what you can see, there is a bulging, what you will be seeing. B, buccal fracture. Another B is for bulging. So bulging in the cortex, what you'll be seeing, but the cortex is still intact. Here, there is an breach in the cortex. A giveaway in the cortex is seen only on the one side. Another side, the cortex is still intact. This is seen in the pediatric age group. That's why it is known as green stick fracture. Backslap, analgesia, ask them to follow with the fracture clinic. Remember this, these green sticks fractures are seen in radius of the ulnar bones, and it is mid-diaphyseal fractures. Next one is sudden unexpected death in infancy or childhood, or simply known as SUDIC. It is a mnemonic. What is SUDIC? Whenever there is an unexpected death in an pediatric age group, especially in an infant, then you call it as an SUDIC. If it's in infants, we call it as an SUDI. If it's in child, we call it as an SUDC. There is nothing special about it, just the childhood. So infancy means up to 24 months they have taken it here, not 1 year, it's 2 years. Up to 2 years, it is called as an infancy in SUDIC. After 2 years, then it is known as SUDC. So you're not expecting. Not expecting means in last 24 hours, you're not expecting this child to die. You might be expecting, for example, someone with a congenital heart disease, surgery has failed, and you're expecting this child might expire at any point of time. That is not an SUDIC. Okay, a healthy child, 24 hours before, you're not expecting anything to go wrong with the child. And suddenly the child has died in next 24 hours. That is suggestive of an SUDIC. SUDIC is the presentation. At the point of the presentation, we label them as a SUDIC. Later on, you might find by doing a postmortem and biopsies, everything, you might find the obvious underlying cause. There might be an inborn error of metabolism. There might be an undiagnosed congenital heart disease. Something is wrong there. You might find it on a later stage. It might be in toxins which have caused this one. That's a different thing. At the presentation, an unexpected death which happens where you're not expecting death to happen within 24 hours in an infancy or a childhood, then it is known as SUDIC. Then what is stillbirth? Stillbirth is at the time of the birth itself, the newborn is dead. While birth itself, it is dead. In presence of a medical professional. Most of the time, births are conducted, a normal delivery is conducted by a midwife. Midwife should be present there. Then only you call it as an stillbirth. You do not label it as a SUDIC. When do you label it as a SUDIC? There is no midwife. There is no one. There is no medical professional who is present. There is no nurse. There is no midwife. There is no doctor who is present. And this child is dead. They say that at the time of the birth itself, the child was dead. But still, we label it as a SUDIC because there was no medical professional present there to say that, yes, the child was dead at the time. It might not be dead. It might be just an aspiration. They couldn't resuscitate because no medical professional was there. That's why we still label it as in SUDIC, not an stillbirth. What are the risk factors for SUDIC? Risk factors are prone position or side position of the sleeping of the baby. Prone means sleeping on the tummy or sleeping on the side, left lateral or right lateral side. Co-sleeping, sleeping along with their parents in the single bed or sofa or an armchair. That is a high risk factor. Few parents do wrap their kids a lot and keep the room temperature on a very higher side, resulting in hyperthermia and death. That is a risk factor. Soft, very soft beddings shouldn't be used. Loose bedding shouldn't be used. There shouldn't be any cloth lying there. They can get suffocated by the cloth. A soft bedding can cause suffocation, especially they go into the prone positions. Second-hand mattresses are important. Poor antenatal care. Mother didn't have a good antenatal care at all. Mom was smoking during the pregnancy, or there is a smoker in the house who smokes inside the house in front of the baby. There is a drug or an alcoholic use which is present in the family. Other maternal causes like young age, like 18, 19 years, the mom age is. Increased age parity, short interval between the pregnancies, just few months apart, there are two pregnancies, twin pregnancies, or low socioeconomic status, previous safeguarding issues are there, family history of SUDIC, all are the risk factors. These are the main risk factors. You need to consider other risk factors also. What are the protective factors? Room sharing. What do I mean by room sharing? The baby is in the same room as that of the parents, but not in the same cot, or not in the same sofa, or not in the same chair. It's there in the same room, but sleeping apart. Breastfeeding is protective. Exclusively breastfeeding is protective. Using pacifiers or dummies are helpful. Making sure the kid gets all the immunization jabs is protective against SUDIC. What happens scenario? In a real scenario, when you are working, imagine yourself, you're working in the NHS department. Okay, NHS department has a red phone. Literally, the phone color also will be red in most of the departments. So red phones rings. Who rings this red phone? You pick the call, the paramedic is calling you. So what does the paramedic says? The paramedic says this, I have come across here for an emergency call here. I see that there is an infant or a child, for that example, is not breathing, is in the cardiac arrest. What do you want me to do at that point of time? At that point of time, tell them if it is appropriate to resuscitate, resuscitate. That means what is appropriate to resuscitate? The kid has gone into rigor mortis. That means the kid is dead from a long time. It is not something which has happened with few minutes back. Or the kid is still warm. It is not cold. There is no rigor mortis which is present. That means they can resuscitate. Tell them resuscitate. If you feel kid can be resuscitated, go ahead with the resuscitation. Call the police at the scene. If there any family or siblings are present there, make sure for their safety and come to the emergency department immediately. So the most important thing is ask them to start resuscitation if it is appropriate and come to the emergency department. Come to the emergency department. Along with it, call the police and make sure the siblings are also at safe because there is a death in the family. There might be another kid which is 3 or 4 years old. That kid is also at risk because we don't know what has happened. It might be a carbon monoxide poisoning. There might be a carbon dioxide poisoning high risk in that house because there is something is burning in the house. So make sure police is there and siblings are also at safe. What you will be doing, immediately you will call your consultant pediatrician who is on call or who is on the floor at that point of time. Involve the senior investigating officer. That's you are doing it. Sometimes paramedics would have done it. If they have not done it, you will be calling the senior investigating officer. Tell them to come to the emergency department immediately because we are expecting a SUDIC. Tell the consultant pediatrician that we are expecting a SUDIC. Come to the emergency or come down to the emergency department immediately. Once they come to the emergency department, if you feel resuscitation is appropriate, if you feel there is an pulse or a feeble pulse or there is a shockable rhythm which is present, the kid is still warm, not in the rigor mortis, continue with the resuscitation. No, there is no point in, there is already rigidity. The child is very cold to touch. There is a cyanosis which has completely developed. The kid is no more. The pupils are dilated and fixed. At that point of time, you'll stop the resuscitation. As we are discussing about SUDIC here, we'll assume that either the resuscitation was unsuccessful or there was no point in doing resuscitation. The kid is going to die or is already died. So family should be given the option to be present in the resuscitation room. You shouldn't be telling the family to be outside the resuscitation room. We need to resuscitate here. Do not come and hamper our resuscitation. No, that is a very, very wrong approach. You need to allow the family members to be with the kid, to be with the infant. Even you can allow the family member to hold the child. Okay, as this is dead child, you will be withdrawing the support. What support? You might have intubated and connected to the mechanical ventilator or doing a back mask ventilation. You might have put an IV line. You might have put a central line. So all these things will be removed eventually. So you can ask them to hold the child. It helps with the grieving for the parents. So they should be with the child. They should be holding the child in ideally. Sometimes they might refuse it. They might not like it. Then you need to respect their wishes. But most of the time, you need to encourage them to be with the kid, encourage them to hold the kid. Then you will remove the lines and tubes. You will not remove it immediately. That's why I mentioned it as do not remove any lines and tubes. You will not remove it immediately. There would have been guidelines set by the coroner. You need to follow the coroner. One of the guidelines you need to be aware of is when to remove the ET tube. ET tube should only be removed after an senior anesthetic or an senior doctor comes and confirms that the ET tube is inside the trachea. Then only you can remove it. And that person shouldn't have been involved in the resuscitation. For example, you will call an consultant anesthetic to come down to make sure that the ET tube was inside the trachea. Then only you can remove it. Along with it, you will be involving the coroner, social services, and child death overview panels. Everyone will be involved. The whole team should be there by this point of time, what we are expecting. This is the complete thing. So remember, whenever you get in call, paramedics should bring the baby to the emergency department. Parents should be there with the child. I keep on saying that kid should be brought to the emergency department. Why? If the paramedics were confirmed that kid is dead, doctor, for sure, pupils are dilated and fixed, it is cold body and rigor mortis has developed. till they have to come to the emergency department, because you need to evaluate and see what is the underlying cause. Various investigations needs to be done. For example, you need to see whether there is a metabolic disorder is present in this individual, or there is a full skeletal survey should be done. Various cultures will be taken, micro SS will be done, toxicology screening should be done. For this reason, they have to come to the emergency department. They cannot just leave the kid there. They have to come to the emergency department. All this should be done in the emergency department. Some might be done in the mortuary, some might be done in the ED department itself, but they have to come to the emergency department. Once this part is done, this is what you are doing in the emergency department. This is the whole thing what your head said. I put across in the words here so that it's easier for you guys to remember. Okay, once you have this, it takes months together to come to a conclusion. After you involve the coroner and all this algorithm I have put up to, just for your reference, you did not remember any of this part, what I have said, what is mentioned here. Here, I have just put up to stress the point that it takes around 6 months to come to a conclusion. What is child death overview panel will sit together and come to a conclusion. What is the cause for it? What actions needs to be taken to prevent this to happen in the future? So it takes months together. What needs to be done in the emergency department will be checked, because you are at the registrar level. It is not important to remember or go through what will happen later on, because you're not at the consultant level, you're at a registrar level. So what needs to be done in the emergency department, you need to be aware. So this is important point. Neonatal jaundice. Whenever there is a neonatal jaundice that is less than 1 month age group, they come with a jaundice, get an LFT done, see whether there is increased conjugated bilirubin or unconjugated bilirubin. If it is increased unconjugated bilirubin, it can be a physiological jaundice or a pathological jaundice. Physiological jaundice usually appears, or it appears after 24 hours of the birth. If it appears within 24 hours of the birth, then you need to consider it as to be a pathological jaundice. Most of the time, it is because of type 2 hypersensitivity reaction and hemolysis what is happening. Sometimes it might be non-hemolytic also. This further evaluation is more for the pediatric. If it is unconjugated, it is always an pathological cause. It might be hepatic or it might be extrahepatic. Hepatic, like a neonatal hepatitis has happened. Extrahepatic, it might be an biliary atresia or an torch infection. Biliary atresia is basically there is no opening for the bile secretions to come out. So this is the gallbladder. There is no opening. There is no cystic duct is completely closed. That's why it is known as biliary atresia. Torch infections are toxoplasmosis, rubella, cytomegalovirus, herpes simplex virus, HIV. These are all known as torch infections. TO or CH, torch infections, they are known as. You need to be aware of. So they can test you. They can give you in the examinations the LFT findings where conjugated bilirubin is on the higher side. Suspect either neonatal hepatitis, biliary atresia, or torch infections. If they give an unconjugated bilirubin, think of it can be physiological, because the baby is 2 days old, more than 24 hours. Less than 24 hours, it is always pathological for you. Which are the babies are more likely to develop significant hyperbilirubin? Significant hyperbilirubin is if the jaundice starts appearing in the first 24 hours itself, because it is a pathological. Mother wants to feed the baby exclusively breast milk. If the gestational age is less than 38 weeks, that is preterm babies are at high risk of developing significant hyperbilirubinemia. If the previous siblings had neonatal jaundice which required an phototherapy, also you need to consider as an high risk to develop significant hyperbilirubinemia. How do you look them? First, you visualize them. Mainly, you'll visualize the sclera, the white part of your eyes, to see that there is yellowish discolorization. This is the most preferred, and it is preferred that you see in the natural light than seeing in an artificial light. Mainly because artificial light, some lights are yellowish in color. They can mimic as an jaundice. It might confuse you. For that reason, they always prefer you. It's always preferred to see in a natural light rather than seeing in an artificial light. Do not only rely on the visual inspection. For example, oh, it is very yellowish in color. Yes, it is on the higher side. Let me start the phototherapy. No, you need to have an exact values. The preferred method of checking the bilirubin is using a transcutaneous. This is a device, a transcutaneous. It's a laser device, transcutaneous bilirubinometer, what we call it. Just use it, it will give you a reading. It is preferred only in babies whose gestational age is at least 35 weeks or older. who are less than 35 weeks, you need to get serum bilirubin levels. If this transcutaneous bilirubinometer gives a reading of more than 250, then confirm the reading what you had on its serum bilirubin. If the kid has been presented within the first 24 hours of the child's age, that means in the first day of the child, the baby has presented, then you need to directly check the serum bilirubin levels. Transcutaneous bilirubimeters are not sensitive enough to pick it up in that age group, that is in hours. So what you do, depending on what hour of the age they are presented with, then you will have various readings you'll be seeing. Depending on that, what treatment should be given will be decided. For example, it is severely on the higher side, exchange transfusion might be required. It is somewhere between, then phototherapy is required. Sometimes they might just observe and admit and consider giving phototherapy if it worsens. Sometimes it might be slightly on the higher side where they will repeat the bilirubin levels after 6 to 12 hours. That's how you will be treating them. You need not remember any of these values. So the treatment options I wanted to stress on the treatment options depends on the bilirubin levels. That's why it is important to know which investigation to get it done. So exchange transfusion, phototherapy, just conservative management. These are the three different options. In conservative management, you need to again check the bilirubin levels after 6 to 12 hours. You need to ask them to come back to the emergency department or meet up with the pediatrician in next 6 to 12 hours. Anyone has questions? You can ask me. Difference between type 1 and type 4. There is an obvious difference between type 1 and type 4 Slater-Harris classification. I'm assuming you're asking about Slater-Harris classification here. So this is a type 1. This is a type 4. There is an obvious. Here, type 1, there's only separation between the metaphysis and epiphysis. In type 4, there is a fracture which is through and through. That is through the epiphysis and the metaphysis, what you're seeing. That is the differentiating factor between type 1 and type 2. There is a cross difference between the two. Which type posterior or anterior X-ray of the elbow dislocation in the slide? In the slide, it is a posterior elbow dislocation what is present. Whenever we talk about a dislocation or whenever we talk about, for that matter, any dislocation or any fractures we are talking about, the distal part is always taken. The distal part is more posterior. That's why we call it as a posterior dislocation. If the distal part is more anterior, then we call it as an anterior dislocation. Same thing holds good for hip dislocation. Same thing holds good for shoulder dislocation. So you take it any dislocation, same thing holds good. You need to look at the distal part. This is the proximal part. This is the distal part. The distal part is posterior, so it is posterior dislocation. If it was an anterior, then it would have been an anterior dislocation. Any other questions anyone has? You can type it. I'll go through it and reply at a later stage. So we'll get into the recall questions now. Anyone has any doubts, you can ask me. Okay, no one has any doubts, so we'll go with the questions. We have an 11 years old boy was brought to the emergency department by his dad to the emergency department. He complains of right knee pain. Since last 4 to 5 days, it has gradually worsened over the time. He denies any trauma. So there is absolutely no trauma is there. Vital parameters are within normal limits. He denies any fever also. X-ray of the knee is given below. What is the obvious diagnosis? Here they are asking. So I can see most of you are picking up Osgood-Schlatters disease. Yes, that is absolutely correct. So this patient is having an Osgood-Schlatters disease. Why? We can see here, this is tibial tuberosity. Tibial tuberosity, there is a fracture, Eval's fracture. It is not a trauma which is present here. The knee pain is there since last 4 to 5 days. That's why it is known as Osgood-Schlatters disease. Here is where the patellar tendon gets inserted. A 2 days old baby was brought to the MS department by a worried mom. She complains that the baby is lethargic, refusing to feed, running a high temperature. On further questioning, number of wet diapers are already reduced. You are suspecting an early neonatal sepsis. Which one of the following statements are true regarding the sample collection they are asking? So which one of this true? They are asking what you need to be aware of. I see most of you are picking three. Anyone pick up any other thing you suspect other than 3? Anyone? Yes, 3 is the right answer here. Why is the 3 is the right answer? Why is not the other answers? Taking 2 samples in a neonate is not preferred, or if possible, you can take it at least 1 sample, what they say. In adults, we say that at least 2 samples from 2 different sites is required. In a pediatric age group, 1 sample is sufficient. two samples are not a must. If possible, you can get it, but it is not a must. What you need to remember. So it is absolutely not a must. If it is possible, you can get it done. That's what you need to remember. That is an additional thing. Next thing is take urine for microscopy. In early neonatal sepsis, microscopy is not recommended. Only in late neonatal sepsis, microscopy is recommended. That's what you need to remember. Next thing is amount of sample should be at least 1 cc, that is 1 ml. Yes, absolutely right. At least 1 ml you should collect it. Admit the baby in NICU without investigations? Absolutely not. You need to evaluate, then only go ahead with the admissions without doing anything. You cannot dump the baby into the NICU, that is neonatal ICU. Lumbar puncture is a must to be performed in the ED. It is not a must. It needs to be done, but it is not a must to be performed in the ED itself. You can perform it in the wards itself after admitting in an NICU. Also, you can perform it. It need not be done in the emergency department itself. You need to do it in early neurologist. It is recommended you do it in LP, but it is not a must to be done in the emergency department. Can be done at a later stage. That's why the most appropriate answer, the most appropriate answer here is the third one. A 4 days old baby was brought to the MS department by worried parents. The baby was delivered in an hospital 4 days back by NC section. Vaccinations are up to date. The parents complain that the baby is in distress after every feed. They deny any color change during the episode. X-ray is taken and shown below. What's the likely diagnosis? What are we seeing on an X-ray? On an X-ray, you can see the bubble loops. These are all bubble loops, what you're seeing. These bubble loops are seen here on the X-ray in the thoracic cavity. Suggestion of there should be some passage from the diaphragm going in. This passage is nothing known as diaphragmatic hernia. Presence of an organ which is not supposed to be in that location, then it is known as hernia. So it is a diaphragmatic hernia what the patient is having here. Next one is a 5 years old child accidentally spilled hot water over both his forearms. He's brought to the emergency department by his parents. On examination, his vital parameters are within normal limits. Second-degree burns are noted over the forearm on the both sides. The kid is complaining of severe pain. What is the non-pharmacological treatment? This we have already discussed in major trauma chapter. So anyone remembers what we have discussed in the major trauma chapter here? So yes, you will be dressing it. So we will be dressing it as one of you are suggesting it by a clinch film. Clinch film is the preferred dressing here because it will be transparent. It can be seen where it is going wrong. So clinch film dressing is the preferred one. Why dressing is preferred? How does the pain is reduced by the dressing? Dressing will reduce the pain because the nerve endings are exposed in a burn, especially in second-degree burns, nerve endings are exposed. So even a cold breeze which is breezing over it can stimulate this nerve and cause severe pain. So if you close it and wrap it and dress it, then it will help to reduce the pain drastically. That's why dressing is the preferred one. A 9 weeks old baby was brought to the emergency department by her mother with complaints of vomiting after every feed and loss of weight. Vaccinations are up to date. Vomiters had only food particles. On examination, the patient is dehydrated, tachycardic, abdomen is soft. Capillary blood gas shows hypokalemic metabolic alkalosis. What's the most probable diagnosis here? This itself is a cue away because in the stomach you have an HCl. So the patient is vomiting out the HCl what is present. So something is causing obstruction here because the vomiters had only the food particles. Nothing else was present in this food particles. So what is it really suggestive of? Is it suggestive of an pyloric stenosis? This is because of hypertrophy of the pyloric part of the stomach. A mother Our mother has brought an 8 months old baby to the emergency department. She demands to be seen by the doctor as soon as possible. She has brought the baby and she thought that baby died. Okay, something very seriously has happened here. Upon further questioning, she mentions that the baby has lost the consciousness for less than a minute's time. However, the baby is now active and well and playing. That means recovered completely. The nurse has documented the vital parameters which are completely normal. So what has happened? This is a classical definition of an BRUVI, brief unresolved, brief resolved event. We call it as in BRUVI. Brief resolved unexplained event is known as BRUVI. So this is a classical definition because it lasted for less than 1 minute. The baby is back to the baseline. Yes. And one of the following, like loss of consciousness or altered level of consciousness, color change should be present, a breathing abnormality, or tone change should be present. Here, there was a loss of consciousness. Everything fits into the diagnosis or the definition of the BRUVI. A 2 years old boy, yes, less than 2 months, it is an 8 months old baby. It fits in. less than, sorry, less than not 1 month, less than 1 year. That is 3 months or 12 months. A 2 years old boy was brought to the emergency department by his mother, explaining that the boy has a dry cough. Sounds like an barking cough since couple of days. It is worse since evening. On examination. You notice there is a stridor on examination. The vital parameters are given where there is a kid is febrile. What's the most common organism? So barking cough plus and stridor, which is present in this kid, plus and dry cough. Barking cough itself is a giveaway diagnosis for you for and croup. So this is a diagnosis of croup. Most common organism causing and croup is parainfluenza virus. So the right diagnosis here is the parainfluenza virus. A 10 years old kid has come to the emergency department with an limb. The vital parameters are fine. X-ray has been given. 10 years is the age group where Perthes disease is very commonly seen. On an X-ray, what we are seeing, avascular necrosis findings are seen, where joint space is increased, few sclerotic changes are seen, few rarefactions are seen, suggestive of an Perthes disease. So it is a classical X-ray of an Perthes disease. A 18 hours old child was brought to the MS department by a worried parent. The child has discharged 8 hours back with the icterus. The baby was born at the 37 weeks. It was a normal vaginal delivery. On examination, notice that the sclera is yellowish in color. What is the most appropriate next step? So it is 18 hours old, less than 24 hours old, and has an yellowish discolorization. So the best investigation here is to do an capillary bilirubin levels. Okay. First, you need to know the bilirubin levels. Then only you can decide what treatment needs to be given. Transcutaneous bilirubin levels are not preferred in less than 24 hours babies. A 3 years old boy brought to the emergency department by his dad. He was playing with a kid, sibling slipped and fell down, resulting in a fall and sustaining an injury to the elbow. He is not moving his upper limb since the fall. On examination, the vitals are fine. There is a swelling around the long joint. Restricted movements are seen. X-rays given. What's the likely diagnosis they are asking? So what is the likely diagnosis here? Sorry. What is the likely diagnosis here? What we can do is we cannot see any obvious fracture lines here. So whenever in a kid fallen down on an elbow not moving, draw an anterior humeral line. When you draw an anterior humeral line, it is not bisecting the capitulum, which is suggestive of an supracondylar fracture. Along with it, if you look closely, there is very slight amount of posterior fat pad sign is also present, which altogether is suggestive of an supracondylar fracture. It's a type 1 supracondylar fracture. A 7 years old boy was brought to the emergency department by his mom. He started complaining of a knee pain since last 3 to 4 days. He was playing a football worse since then. He has no history of fall or trauma. Vital parameters are fine. Knee X-ray is given below. What's the likely diagnosis? It is again repeat. You can see there is an avulsion fracture of the tibial tuberosity. There is no history of trauma. That means he has directly not fallen on the knee. It suggests to you all of Osgood-Schlatter's disease. It is not an avulsion fracture of the tibial. It is known as Osgood-Schlatter's disease because it's a pediatric age group. If it was a trauma, then we would have labeled it as an avulsion fracture of the tibial tuberosity fracture. Because it is not an trauma, that's why we're calling it as an Osgood-Schlatter's disease. You're teaching about Slatter-Harris classification to a group of students who are newly posted to the emergency department. Which of the following is, according to the Slatter-Harris classification, is correct? They're asking. So which of the statement is correct? Similar question had appeared in previous diet also where they were testing for the type 1 definition. Here we'll go through with each one of this so it becomes easier for you to understand. So type 1 is a crush injury to the epiphyseal plate. No, it is an type 5. It is not type 1. Type 2, a vertical fracture through the epiphyseal joining that through the epiphyseal plate. What it is known as, anyone? Yes, type 4 is the right one. What you are mentioning here, type 4, a fracture passing through the articular surface through the epiphyseal plate into the metaphysis is the type 4. This is basically the definition of type 3. This is a small piece of metaphyseal separating from the epiphysis is the definition of type 2. This is the definition of type 1 where the epiphysis is separated or slipped from the metaphysis is the type 5. Okay, remember the definitions. I have mixed it together. The right one is here, the fourth one. The right one in the last diet was type 1. Okay, so they can test you any of these fractures with an X-ray or without an X-ray. They're directly asking what is the likely fracture here. Likely fracture, I can obviously see a fracture line here. This is the fracture line what I am seeing here. This fracture line itself is enough for me to suggest that it is an supracondylar fracture. Along with it, there is a posterior fat pad sign also. So direct diagnosis here of an supracondylar fracture. A 6 months old child was brought to the emergency department by her parents. They felt like the child was going to die. Whenever they say going to die, start thinking of an brewery. 6 months old fits into the category of less than 12 months. Less than 12 months or less than 1 year, which lasted for less than 1 minute. Soon after the episode, the child was completely back to the normal, again fits into the groovy, brought to the emergency department, playing with the toys, vital parameters of spine. Examination was unremarkable. Which one of the following likely to be present during the episode? Which one of the following? I said four things should, one of the four should be, sorry, one among these four. That is, one is the color change should be present. Another thing is something wrong with the breathing should be present. Either apnea or increased or absent breathing should be there. Something wrong with the tone. Something wrong with the consciousness level should be present. So what is present here? Pallor. Something wrong with the color. So this is the first one. A 2 years old baby was brought to the MS department by her parents. They complained of multiple episodes of vomiting since 3 to 4 days. The symptoms have worsened today. There is no history of outside food consumption. There is no similar complaints in the past. Online examination, the kid is moderately dehydrated with tachycardia. You decide to start her on IV fluids. The weight they have given, they are asking about the maintenance fluid. Maintenance fluid over 24 hours. So first 10 kgs is 100 per kg I'm talking about. Next 5 kgs is 50. So this will be 1000. This will be 250. So total will be 1250 ml. So the right answer is the fourth one. They're asking which one of the following red flags for fever under 5. Fever under 5, the red flag only thing is grunting. At least remember grunting, it is tested multiple times in the previous exam. So grunting is present here. This has been tested multiple times in the previous exam. Be aware of it. CRP, also be aware of it. It is present as an amber sign, not as a red sign. People get confused with the CRPs, so be aware of the CRP. No smile also comes here. Another thing, no smile, one of the options for the no smile also comes here. Fever more than 5 days also comes here in the amber. So out of all this following, only the grunting is suggestive of a red flag under the fever under 5. A 4 days old baby was brought to the MS department with complaints of reduced feeding and in fever. Antenatal care was uneventful. Vital parameters are as follows. They are given here. With the kid is febrile. You are suspecting an early onset neonatal sepsis. The risk factor for early onset neonatal sepsis are all below except they are asking. This is an obvious maternal group B streptococcal colonization. Preterm delivery before 37 weeks. Yes. Feeds intolerance. Yes. Hypoxia. Yes. What about jaundice after 24 hours? It is most of the time it is physiological. So this shouldn't be a risk factor. Jaundice less than 24 hours of birth, if it is present, then it becomes a red flag. So this is the right answer here. So always have a closer look. They're asking about the risk factors. Have a closer look at the risk factors. You need to be aware of the risk factors. They can test in the various ways. So there is no other shortcut for you to remember. So you need to be aware of all the risk factors. 10 years old child was brought to the emergency department by the parent. The parents noticed that child has been limping since last few days. X-ray has been given. They're asking what is the line they have drawn here. The line they have drawn here, which is abnormal, just below the ossifying center of the greater tuberosity, they have drawn a line and it is not bisecting the head. This line is known as Killian's line. This sign is known as Tritovan sign. So they're asking about the line. Line is Killian's line here. Bohar's angle is used for calcaneum fractures. Radiocapitellar line for radial head dislocation. Greater tubercle line, nothing exists. Neck of femur line doesn't exist, or it is not important for us. X-ray of the hip joint is given. This kid has presented with a limp, 14 years old. Age itself gives off a we are thinking of Sufi in this age group. Again, we will see that left limb. So this is the right side, left side. Left side, I'll draw a line because I'm strongly suspecting during the age group below the level of the greater tuberosity. It is not bisecting the head. So it is again suggestive of a slipped upper femoral epiphysis. But interestingly, on the other side also, if you draw this finding is positive. This is basically suggestive of it is bilateral. This patient is having bilateral, though it has presented with a unilateral symptom, this patient has a bilateral. Most of the time, bilateral hip replacement will be required. You have a 4 weeks old baby was referred to the MS department by JP on arrival to the on arrival to the ED. The baby is received in the resuscitation B. Vital parameters says that high grade temperature, there's tachycardia, there is some tachypnea is present, there is a diffuse rash is also present. You're suspecting a meningitis, third-degree cephalosporins have, third generation cephalosporins have been started. You start the baby on amoxicillin to cover which one of the organisms they're asking. Especially in the pediatric age group, we add amoxicillin, or for that matter, ampicillin is added to cover listeria. Listeria is not covered by third generation of cephalosporins. In adults, also more than 55 years of age group, also we add up listeria in meningitis cases. They are asking which is the Slater-Harris classification. This is Slater-Harris classification. Only the lower part, that is epiphyseal end, is involved. Epiphyseal end is involved. Third, it is a Slater-Harris classification. 3 is the right answer. This is an interesting one. Before we go ahead, we'll see what is Ray's syndrome. Okay, this is Ray's syndrome was more commonly seen few decades back. Now it is very commonly not seen. Why was it seen few decades back? Few decades back, aspirin was very commonly used for fever. Anyone has a fever, give aspirin. Anyone has a headache, give aspirin. Now, how commonly do we use aspirin? We do not use. Unless he's taking an aspirin, we think of, oh, did he had a stroke or did he have any MI so that he's taking an aspirin? Otherwise, as a painkiller or as an antipyretic, we never use an aspirin at all. What happens if you give an aspirin in a pediatric age group for an viral fever? If you give it in a pediatric age group for a viral fever, it affects the mitochondria. There will be no ATP synthesis. Mitochondria is basically the cell organelle which synthesizes the ATP, which is the energy currency of your cells. This causes injury to the hepatocytes, and this causes injury to your brain cells, neurons of your brain cells, resulting in encephalopathy, liver damage. These are the two classical features. Management is only supportive, you cannot do anything. Now let's go back to this question what we are having. We have a 2 years old child who was brought to the emergency department with a history of fever. Sore throat was there. Mostly it is an pharyngitis or tonsillitis. The child lives with the grandparents. That is one of the key to understand here. The child was given medicine for the fever but doesn't remember the medicine name. Now he has developed the upper abdominal pain with altered sensorium. Altered sensorium is suggestive of CNS involvement. Upper abdominal, we are thinking of liver involvement is there. Along with it, if you see the bilirubin levels are on the higher side, AST levels are on the higher side, ammonias are also on the higher side. What is the likely diagnosis? Liver plus CNS involvement, along with a history of fever staying with the grandparents. Grandparents most likely have given an aspirin for the fever, which has resulted in damage to the liver and encephalopathy known as Ray's syndrome. This is an Ray syndrome, not an hepatic encephalopathy. Hepatic encephalopathy cannot develop so acutely. Though the ammonia is on the higher side, it is more commonly seen in more commonly seen in adults with a chronic history. This is a classical history of Ray syndrome. A 7 years old kid was brought to the MS department by his mom as he was not feeling well and had a high grade fever. On examination, you find there is a bilateral cheek swelling suggestive of an peritonitis. There's a diffuse rash, high grade temperature you are suspecting, and mumps in this patient. When do you notify this disease to the concerned authorities? This is an routine notification. What you're doing, routine notification should be done within 3 days. That is 72 hours of suspecting. So the right answer here is the second one, after suspecting. So if you see here, mumps comes as a routine here, routine. That's why you need to notify within 72 hours of suspecting. A 2 years old kid was brought to the emergency department complaining of a cough and cold since last 3 days. Since last night, he is having a noisy breathing in the ED. The kid is sitting in a tripod position, still not interacting with anyone, slightly drowsy with an audible stridor. These are the vital parameters where I can see the oxygen levels are on the lower side. Oxygen has been already started by the nurse. What is the next step, best step in the management of this patient? So what has happened here? We are suspecting a croup because of the cough which is present, coryzal symptoms which are present here, along with the stridor, all is suggestive of an croup. In a croup, we always do an Wesley's classification or Wesley's score. Let's do an Wesley score here. The patient is having an stridor, audible stridor in the rest position, so it gets 2 points. Saturation or less than 92%, it gets 5 points. The kid is slightly drowsy, again, altered sensorium gets 5 points. Altogether, it is 12, suggestive of an life-threatening croup. The patient is having a life-threatening croup here. How do we treat? The stepwise. Stepwise is first give the oxygen supplement, step 1. Step 2 is refer. That means involve the pediatricians as well as the ENT. Third step is to give adrenaline nebulization. First step is already done by the nurse by giving the oxygen supplements. Second step is not mentioned here, so we cannot choose that one. Adrenaline is mentioned here, so you're choosing adrenaline nebulization. So the right answer here is adrenaline nebulization. Life-threatening group, step 1, oxygen, step 2, senior anesthetic and ENT, what you'll be involving, nebulize with the adrenaline. So remember the steps, it is important. A 9 months old child was brought to the MS department by the parents complaining of a child being completely floppy, turning bluing, lasting for around 5 to 10 seconds. Kid has completely recovered. The child experienced a similar episodes 10 days back. Didn't seek anything because the child completely recovered. He is currently completely stable and happily playing with the mom. What is the next best step? So, do we are thinking of an Brewy? Does this have an low risk or an high risk? It is a high risk or low risk? High or low risk? It is an high risk because this is second episode. First episode was 10 days back. Whenever it is in second episode, it becomes an high risk. If it is a high risk, the minimum what you need to do is ECG and capillary blood gas, and you need to admit to do an to basically cardiorespiratory evaluation needs to be done and observation needs to be done, needs to be connected to the cardiac monitor. So fourth one is the right answer here. Which of the following variants for an investigation they're asking? So what is this case about? A 9 months old floppy turning 5 to 10 seconds. On examination, the kid is happy and hemodynamically stable. When do you admit? CPR given by parents? No, it should be trained practitioners. More than 60 days, it is low risk. First event, low risk. Less than 1 minute duration, low risk. CPR given by trained practitioner? Yes, that is the right answer. 5 years old kid was brought to the MS department by her parents. She complains of abdominal pain on and off, associated with joint swelling and pain. There is a rash as shown in the picture. This is a maculopapillary rash is present. What are you suspecting? So, abdominal involvement. So, GI tract is involved. Joint involvement along with the joint swelling. So, arthralgia and periarticular swelling is present. Along with it, a rash is present. Skin involvement is present. So, all this going in the favor of phenolphthalein purpura. The one other thing what is involved is kidneys. Kidneys usually cause glomerulonephritis. Glomerulonephritis on an urine routine, you can see positive for RBCs. So getting an urine routine is important here. A 2 years old baby was brought to the MS department by the parents with an alleged history of consumption of magnet 4 days back. The baby was seen by your colleague in the ED, was advised to come back to the MS department if red flag signs are appeared. Now the kid has developed abdominal pain, had 2 episodes of vomiting. Therefore, the parents have got back to the emergency department. You get an X-ray done. Still, the magnet is in the stomach, in the peritoneal cavity. Where is it? It's well below the diaphragm. Usually, stomach comes here. It's well below the diaphragm, stomach level. Also, it's not in the duodenum. Also, it's somewhere in the small intestine because it is in the center part of the abdomen. Endoscopy, whenever you do to remove the endoscopy, they can reach up to the duodenum. They cannot reach into the jejunum or ileum. So surgery has to be done. What is the surgery known as? It is a laparotomy what you'll be doing. Endoscopy is a wrong answer because cannot reach there. Why we need to do interventions? Because the child has developed symptoms. Whenever the child has symptoms, you need to remove the magnet. So you'll be doing. Next thing is here question is, we will assume that the vital parameters are stable. Okay, what will be the best next step? Anyone, what will be the best next step if the vital parameters are stable for this kid? Getting a CT scan done. Why? It will give you the exact position where is the foreign object. It will help with the surgery. They need not do and complete open. They can exactly open where they are suspecting. It gives exact location. So it will be helpful with the surgery. So get an CT scan done. Requires a laparotomy eventually. Yes, we are aware, but getting a CT scan done will be helpful for the surgeons. If it is unstable, directly goes to the operation theater. A 4 days old child was brought to the MS department. Mom has noticed that the child is limping since last few days. So limping case it is. On examination, the vital parameters are within normal limits. He is febrile. Restriction of the movements of the right hip joint is noted. There has been no similar complaints in the past. What's the most likely diagnosis? 2 points. One is limping. Another one is febrile. He's febrile currently. So 2 means 40% chances this patient is having a septic arthritis. But have they given a septic arthritis option here? They're not given a septic arthritis option. So you are selecting an transient synovitis. Otherwise, septic arthritis would have been the most likely answer. In transient synovitis, usually there will be a viral fever. Yes, the patient is having some amount of fever here, not seen in other cases. Along with it, there is a limp. That's why we are thinking of a transient synovitis. But remember, whenever you're choosing transient synovitis, always rule out septic arthritis before that. You're suspecting a croup. You're given a dexamethasone orally. Soon after giving dexamethasone, the child has vomited again. What is the best next step? I will add up another option as giving an ondansetron orally. So which one will be the right answer here? Still the right answer will be budesonide here. Why? Because the child is vomiting. If you give orally ondansetron also, it will vomit. So no point in giving ondansetron, waiting for few hours. Waiting for few hours, you need to wait for this to take effect. If not, at least 45 minutes, you need to wait to take the effect. So you're wasting time, one point. Another thing is likelihood of this patient vomiting. This one is also on the higher side. So without pricking the patient, without causing any distress to the kid, how can we treat? We can give a nebulizer here, the steroid nebulizer. So always first step will be to try to give dexamethasone. If dexamethasone is not possible to give it, then try to give a nebulization of budesonide. A 2 years old female kid was brought to the MS department by her parents with a severe abdominal pain. Each episode lasted for a few minutes. In between the episodes, the kid is completely normal. The mother has also noticed that while changing the diapers, the stool color has changed. It is more reddish in color, vital parameters stable. What is the likely diagnosis? This is a paroxysmal abdominal pain. In between the episodes, it is completely stable. Along with it, reddish color stools is suggestive of an current jelly stools. Current jelly stools, along with episodic severe abdominal pain, is suggestive of an intussusception. A 10 days old child has sustained an injury to the elbow. They have got an X-ray done. They're asking what's the most likely diagnosis here. This is all about ossifying centers. You can see plenty of ossifying centers. Elbow is given. This is olecranon, what you're seeing. So what we'll do, we'll go from the radius set. This is the radius, what you are having. Just above the radius, we have the capitulum. Just above the capitulum, we have the lateral epicondyle. All are there. Just adjacent to the, just adjacent to the capitulum, there is a trochlea. Above trochlea, medial epicondyle should be there because trochlea appears after medial epicondyle. What has happened? It has got avulsed here. So medial epicondyle avulsion. This is the most common one because the flexors of the forearm gets inserted here. So if they test you, they'll most likely will test you on that part. A 5 days old child was brought to the emergency department by his parents. Mom noticed a rash over the trunk. He gives a history of sore throat 2 weeks back. Vital parameters are within normal limits. On examination, you see an raised rough rash over the trunk. What is the investigation to support your diagnosis? What is the raised rough rash is suggestive of? It is suggestive of an sandpaper rash because rough it is. Why it is rough? Because the hair follicles are erect. That's why when you peel it, it will be rough and it will be raised kind of rash. This is a classical rash which is seen in scarlet fever. Okay, along with it, usually we see and strawberry tongue also. These are the classical features. Yes, yes, and yes, it's a scarlet fever. Scarlet fever is a complication caused by group A beta hemolytic streptococci, also known as strep pyogeny. So strep pyogeny can be diagnosed with an ASO titers. So it will support your diagnosis if you get an ASO titers. It is not a must to get it done, but it will support your diagnosis. Same question with little bit twist around. Same baby, mom has noticed a rash over the limb. Gives a history of sore throat, same thing, vital parameters stable. On examination, you notice a maculopapular rash over the limbs. What is the likely diagnosis of which investigation you will get it done to support your diagnosis now? Now you will get an urine analysis done. Why are you getting an urine analysis? Because you are suspecting an HSP here. Because a viral infection can predispose to an henotscolin purpura. And involving only the lower limbs, the rash is again suggestive of an henotscolin purpura. So getting an urine analysis is important here because we are seeing the RBCs in the urine analysis. That's why we are getting it done. Okay, so this can be in two ways tested in your exam. We are not sure which one was tested, but be aware of this. A 10 years itself gives me Perthes disease starts ringing in my mind. 10 years, Perthes disease, 7, 8, 9, 10, Perthes disease. X-ray of the hip joint is given. What is the X-ray finding they are asking? X-ray finding, I'll go ahead and have a look here. But this disease doesn't look like there is no, sorry, there is no avascular necrosis, what I can see. Everything seems to be fine. Uh, 10 years is close to adolescent age. That's why what I'll do is I'll start to draw a line, 3 to 1 line. So it is basically positive on both sides, suggestive of and Sufi. Okay, suggestive of and Sufi, it is a 3 to 1 sign which is present here. Slipped upper femoral epiphysis, Sufi stands for. Which one of the following is an indicator of high risk in this patient? Less than 4 years, febrile kid. They are asking fever under 5, high risk. Again, it is a grunting, which you need to remember. It's the same thing which has been tested. All others are not high risk or not red flags. High risk means red flag. A 2 years old child presented with an coryza, that is upper respiratory tract infections. Since morning, he has developed and swelling around the ankle and it is painful. On examination, you notice swelling and tenderness around the ankle joint, a macular rash over the legs. What's the likely diagnosis? Everything fits in here. You just need to get an urine routine to make sure the patient is also having hematuria. It is an HSP, what you're having. Different joints are involved here. Skin is involved here. That's why we are thinking of an HSP. HSP usually is predisposed by a viral infection. It is a vasculitis. Wesley's group score, which of the following marks a single point they are asking? A saturation less than 95 5 points. Cyanosis is taken in US. It is mainly it is taken. It is 4 or 5 points. This is also 4 or 5 points. Instead of saturations, you can take cyanosis if you are in the US. Fever. Fever is not included. It is 0 because it is not included in Wesley's score at all. Strider at rest is 2 points. Mild reduced air entry is 1 point. So out of all these options, fifth one gets the 1 point. So the right answer is the fifth one. So Wesley's group classification is very important. They're asking high risk for Bruvet out of this following. Loss of consciousness, is it a high risk? Color change, apnea, pallor. No, these are all not high risk. They come in the definition of it. Altered sensorium, altered color, and breathing pattern all comes in the definition. High risk pattern. High risk pattern is 31 weeks preterm is a high risk. Low risk will be age more than 32 weeks of birth, more than 32 weeks. Again, corrected age should be more than 45 weeks. So right answer here is the fourth one. A worried ma'am gets her child to the emergency department. Notice that, notice blood in the diapers. Blood in the diapers in this age group, interception for you. Okay, along with it, they have already said that intermittent inconsolable cries since couple of days. She didn't take any help because it is to get resolved by itself. What's the most likely diagnosis? Again, it is an interception. Olulus presents with abdominal obstruction. Hernia, usually it's umbilical hernia. They usually suggest you of a mass. Henops colon purpura, joint involvement, joint pains, periarticular swelling. Some hematuria can be present along with a classical maculopapular rash over the lower limbs. Extensor surface are involved. Pyloric stenosis, usually they present with an vomiting, non-bilous vomiting, where HCl is lost, leading to an metabolic alkalosis with hypocholemia. Before we go into this, let's go into what is osteosarcoma. Osteosarcoma is one of the most commonest orthopedic tumors seen in the pediatric age group. They have a classical appearance known as sunburst appearance. This appearance is known as sunburst appearance. Most commonly, the long bones are involved here. Okay. And because of this sunburst appearance of because of this cancer, this osteosarcoma cancer, basically it is what it causes brittle bones. How do they present? They usually present with a trivial injury. Something like someone just pushed, someone just touched the limb, someone just held the limb, resulted in a fracture. So trivial injury can cause a fracture because the bones has become very brittle. That will be the presentation usually. Ewing sarcoma. Ewing sarcoma is the second most common. Usually the long bones are involved. Doesn't mean only long bones. Axial skeleton can also be involved. They classically present with an onion peel appearance. Onion, you can see like this is known as onion peel. So classically here you can see onion peel appearance is present. This is known as onion peel appearance. So favorite one is to ask an osteosarcoma. They have asked multiple times. That doesn't mean Ewing sarcoma cannot come. Remember the onion appearance, Ewing sarcoma. These are the two common tumors you need to be aware from exam point of view. So what are you seeing here? A sunburst appearance, what you are seeing. It is an osteosarcoma. So what is the presentation? It's a kid who has presented with a trivial injury. They directly given as a trivial injury. Pain has gradually worsened and unable to weight bear. X-ray has been taken. What is the diagnosis? They are asking. It is an osteosarcoma. A 3 years old child was brought to the MS department with complaints of sore throat and cough since last 3 to 4 days. Mom has noticed that there is a barking cough. I'm already thinking of a croup because there is a coryza with a barking cough. Developed in development is appropriate for the age. Vaccine is up to date. The child appears toxic, has stridor, and is sitting still. What is the next step? What is it suggestive of? The child is sitting still, very toxic appearing. That means it is very bad. It is a life-threatening croup what the patient is having. Though enough data is not there to do an Wesley score and really label it, but toxic appearing, sitting still itself should be indicative of and life-threatening croup for this case. Life-threatening croup. If the kid is hypoxia, you'll give oxygen supplement. If hypoxia, otherwise you're not giving oxygen supplement. Second step, to involve the pediatricians, anesthetics, and ENT. Here, anesthetic is there, you're involving that. The third step is to give adrenal embolization. Do not get confused. People get confused in this point. Intubation may not always be required. Adrenal embolizations and giving steroids might require, but when you give these medications, the kid might go into distress and might cause respiratory failure and might go into respiratory arrest. For that reason, we always need backup pediatric anesthetic and ENT surgeons. And pediatrician also, everyone needs to be there. The whole team should be there. Which is the risk factor for early neonatal sepsis? Out of the following, what they are given? Active neonate, obviously not. Postpartum maternal fever. No, it is not postpartum. It's an intrapartum fever should be present. Okay, and it is suggestive, it should be suggestive of a bacterial infection. Delivery after 36 weeks of gestation. No, before 36 weeks of gestation. Jaundice after 24 weeks. No, before 24, not weeks, 24 hours of birth should be present to call it as a pathological, or else it becomes a physiological jaundice after 24 hours. Premature rupture of membrane for 72 hours before delivery. Yes, that is an high risk. Note that it is 18 hours in a treat term and it is more than 24 hours. Okay, by mistake, I have told, though it was written as 48 hours, though it was written as 18 hours itself, by mistake, I have told more than 18 hours in pre-term while taking the class in the last class in the pediatrics. It is 18 hours. What is written is the correct thing. They want you to calculate the maintenance fluid for 14 years, 14 kgs. So first initial 10 kgs, I'll multiply by 100, it becomes 1000. Next 4 kgs, I'll multiply by 50, it will become 200. So it is 1200 over 24 hours needs to be given. What we have calculated is over 24 hours. This again, we can calculate over 1 hour also for the next 4 kgs into 2. So it will be 40. This will be 48 ml per hour also you can calculate it. Okay, there's a two ways. If I calculate it correctly, I'll get back to this one, but there are two ways to calculate it. This is the right calculation for this one where it comes as 1.2 liters over 24 hours. So this is the other way to calculate for the hour. Which one of the following defines type 1 Slater-Hazes classification? This was appeared in the September 24. A crush injury to the epiphyseal plate. It is suggestive of type 5. A vertical fracture through the epiphyseal joints through the epiphyseal plate. Suggestive of a third one. A small piece of metaphyseal separating the epiphysis. Type 2. A fracture passing through the articular surface through the epiphyseal plate into the epiphysis. Type 4. Epiphysis separates or the slips on the metaphysis. Type 1. So the type 1 is the fifth option here. Be aware of the definitions. You're thinking of an Bruvi in this case. Which one of the following will be present in the history to make a diagnosis of a Bruvi? So in history, either color change should be present, tone should be present, or some altered sensorium should be present. Tone altered breathing. Something wrong with the breathing should be present. Out of this following, which one of the following present? Breathing pattern is present here, change in the breathing. That's why this is the right answer, the third one. You have diagnosed with bacterial tracheitis. Which one of the following is true in bacterial tracheitis? Nebulization with adrenaline is not required, might be required. We give in bacterial tracheitis. We do not usually give nebulization with adrenaline in bacterial tracheitis because most of the time it is narrowing because of the copious production of the mucus. So adrenaline might not be helpful, so we do not give it. Strep pyogen is the most common organism, causative organism. No. Okay, that is not the right step. Sorry. Staph aureus is the most commonest organism which causes the bacterial tracheitis. Intubation is not required in most of the cases. No, most of the cases requires intubation. Certain deterioration not possible. It's very likely possible. They are very toxic kid. They can deteriorate at any point of time. Most of the time they present in septic shock. Admission is not required. Required, absolutely required. Oral antibiotics, no IV antibiotics are required. So the right one is F, the first one. A 5 years old child was brought to the emergency department with hip pain and limp in the left lower limb since last 10 days. The GP has treated with patient with a painkiller without any improvement. There is no history of trauma. The X-ray of the hip joint is given. What is the likely diagnosis? X-ray, let's have a look at the X-ray. Limp is there. So I cannot see any avascular necrosis as such. That's a Perthes disease. I'm not suspecting a Sufi, but anyways, I'll draw a line and see it kinds of bisects. Anyways, draw a line and see it kinds of bisects. Or if I keep here also dissects. But this age group, we do not see Sufi. Sufi is seen more in the adolescent. You can rule it out in that manner also here. So what is the likely diagnosis? Perthes, we are ruled out. Sufis, we are ruled out. Developmental hyperplasia, not seen in this age group, ruled out. Transient synovitis can be there. Septic arthritis can be there. But always septic arthritis should be first differential diagnosis. That's why we are choosing septic arthritis over transient synovitis. Which one of the following is a risk factor for SUDIC? Sudden unexplained death of an infant or a child. Which one of this following? Supine position? No, it is not a risk factor. Developmental delay? No. Not vaccinated? No. Immunization completed is actually a protective factor, a good prognostic factor, protective factor. Recent infection, no. Poor antenatal care, yes, this is a risk factor for SUDIC. Remember, the risk factors are different from the good prognostic factors. A father was brought his child to the ED with an alleged history of strong magnet. Remember strong magnet whenever they mention, or earth magnet whenever they mention, you need to remember what are the RCAM guidelines. While playing with the toys, he doesn't know how many magnets this kid has ingested. Currently, the kid is asymptomatic. Vital parameters are within normal limits. Examination is appropriate. What is the most appropriate next step? It is very important for us whenever they ingest a magnet. This patient is asymptomatic. One is symptomatic or asymptomatic is the one thing what you need to be aware of. Second thing you need to be aware of, how many magnets? How many magnets can be known by getting an X-ray done? So do multiple X-rays. It is important not only do one view, you need to do multiple views. AP view and lateral view is preferred one. Why? Because sometimes they might be overlapping and you might see there is only one magnet. So doing in multiple views is helpful in that matter. So we need to do, because if there are more than one magnet is present, immediate removal should be done. That's why. A 4 years old boy was brought to the MS department by his parents. He was seen in the ED accident for accidental injury for battery 2 days back. Currently, the patient is complaining of abdominal pain. On examination, the abdomen is tender with guarding. Vital parameters are within normal limits. Old and new X-ray is given. Old X-ray was here, new X-ray is here. What will be the next best step in the management plan of this patient? This patient is vitally stable. We know this patient has symptoms, requires an laparotomy to be done. So surgeons needs to be involved here. But again, before involving the surgeons, get a CT scan done. It will be helpful because this patient is stable here. That means vitally stable here. After that, you need to get an laparotomy. Sometimes they may not give you CT abdomen as the option, then laparotomy will become the right answer. This is a difficult one. Shouldn't be checked as an emergency exam, emergency medicine exam, but twice it has appeared, including in September 24, it has appeared. In September 24, the age group was given as, I think somewhere around single digit it was. I don't remember. In years it was. Okay, it was an 18 months old child brought to the emergency department by his mother. She complains of a neck swelling. As you can see, neck swelling. There is no history of sore throat since 3 to 4 days. On examination, our vital parameters are within normal. The neck swelling is fluctuating. An image is in given here. It is difficult. We do not learn about cystic hygroma and all. So let us try to understand and try to rule it out. Thyroglossal cyst. Whenever thyroglossal cyst is done, how do you know? Protrusion of tongue will usually move the thyroglossal cyst or anything wrong with the thyroglossal cyst. So it is there in mid. So in midline, this is on lateral side. So you can rule it out. Dermite cyst, consistency of the dermite cyst is hard kind of. Okay, soft to hard, not fluctuating, not a fluid kind of consistency. You can rule it out. Sublingual or submandibular lymph nodes are usually found here in this region you are finding it. And usually history of fever will be there. That's why these lymph nodes are enlarged. No fever, no infection, no inflammation, then you can rule it out. It is a cystic hygroma. Same image has appeared in the last diet, September 24. So be aware it is a cystic hygroma. A 7 days old baby was brought to the MS department by an worried mom. Complaints of an yellowish discolorization of the eye and baby is lethargic. The baby was born full term, normal vision delivery, known complaints. On examination, the baby appears toxic. What is the most appropriate next step? So, what are we suspecting in this kit? One of you has said transcutaneous bilirubin measurements. Yeah, good. Anyone wants to add up anything? Okay, few things we'll put up. There is a jaundice which is present. The kit is appearing toxic. Okay, these are the two points which are very important. Toxic appearance means the kid is really sick, appears very ill. So what are we suspecting with the jaundice and toxic appearing? We are suspecting an late neonatal sepsis. This kid might be in sepsis, late neonatal sepsis, what you're suspecting. In sepsis, which is very important. Treating the jaundice is very important, or treating the sepsis is very important. Treating the sepsis is very important, as we learned from our infectious chapter. Sepsis is very important. Giving antibiotics as soon as possible is very important after collecting the cultures. So giving the antibiotics is important because we are suspecting an late neonatal sepsis in this kid. A 19 years old sorry, 19 years old male came to the ED department with difficulty swallowing. He has migrated with no history of vaccinations. On examination, his vital parameters are within normal limits. There is febrile, ruling of the saliva is present. X-ray is shown below. What's the most likely diagnosis here? X-ray. This is a thumbprint sign, classical. No vaccines again goes in favor of epiglottitis. Drooling of the saliva also goes in favor of epiglottitis, which is very not commonly seen in bacterial tracheitis. And bacterial tracheitis usually presents with copious amount of sputum. Retropharyngeal abscess, usually there should be a soft tissue swelling on the lateral X-ray. You can rule it out. So keeping all this in mind, it is a clear-cut diagnosis of an epiglottitis because of the thumbprint sign. Our father has brought the child to the MS department. He was worried about he might have ingested a strong magnet. Currently, the kid is asymptomatic. However, the observations are normal. His abdomen is soft and non-tender. There are no similar complaints in the past. What is the most appropriate next step? Again, getting the X-rays. Okay, getting X-rays in different views is important. Okay, once you feel it is one magnet, then you can plan to discharge and repeat the X-rays after 6 to 8 hours. You'll be repeating, and radiological reference is required to make sure that there is progression is there. They did not see the all those things can be done. But first thing we need to find out how many magnets are there by getting the X-ray done. Mom gets her son to the MS department who has accidentally ingested a single magnet while he was playing with the toys. Vital parameters are within normal limits. Abdomen is soft, non-tender. You get an X-ray done and confirm it is a single magnet, which is below the level of diaphragm. You plan to discharge with a safety netting. Regarding discharge advice, which one of the following is incorrect? They're asking. Should come back to the emergency department if develops bloody diarrhea? Yes. All curtains having metals, yes, because it can, this magnet which is ingested can attract this metal objects, can cause perforation. So this is correct. Should come back to the ED if the child develops fever. Yes, peritonitis can cause fever. This can ask the mother to look for the magnet in the stools. It is not advised nowadays for a strong magnet, but nowhere they have mentioned a strong magnet here. That's why this is also you can consider correct. Can wear clothes with the metals? No, cannot wear clothes with the metals. That's why it is a right answer. If they mention as a strong magnet, the advice by the RCM or the guidelines from the RCM is they did not observe stools for the magnet. A paramedic has called you for advice on a baby. On arrival at the scene, the baby is dead in his cot. What should be done next? The best thing is bring the baby to the emergency department. You can call the police and inform the authorities, though we tell the paramedics, but ideally you can also call the police. Senior investigation officer can be called. Leave the baby with the parents and return home. Absolutely not. stay there until the baby well-being and authority comes. No, they need to come to the emergency department as soon as possible. Call GP to attend. Absolutely not. They should bring the baby immediately back. This is nothing but sudic, what you are having. A 5 years old child is bought in by his parents. After they suspected he ingested a father's stress relieving desk toy, which contained a super strong magnet. So what are we thinking about? This is an RKM guideline which is based on the child is well and asymptomatic. Abdominal X-ray reveals single foreign body located in the stomach. You plan to discharge the patient with instruction to return back to the emergency department for follow-up abdominal X-ray. Which one of the following statements is correct regarding his follow-up? Refer to the pediatric surgeons. No, we are not doing a referral to the pediatric surgeons. We are asking them to come back to the emergency department. ED clinicians can interrupt an abdominal X-ray to check the progression. No, it has to be by radiologist. Okay, it's not by us. He should return to the emergency department after 24 hours for a repeat X-ray. Repeat X-ray, do we wait for 24 hours? No, we do not. We do not wait for 24 hours. It's 6 to 12 hours, maximum 12 hours what we can wait for a repeat X-ray. That repeat abdominal X-ray should be performed in the same position. Yes, it is true, should be performed in the same position so that we can compare with the previous X-ray and know whether there is progression or not. And this should be known, or this should be commented by the radiologist. Observe the stools daily until the magnet is passed. It is not recommended. So the fourth one is the right answer. A 3 years old kid was brought to the emergency department by the mom. She complains of a kid having a right hip pain. Initially, the kid has limping, but now has started crawling. Because of the limping, they have gone to crawling position. So it is a limp case. She also says that the kid had an viral fever few days back. On examination, the hip is abducted and flexed. Observations of within normal limits was the most likely diagnosis. So first thing comes in our mind is septic arthritis. Let's score the septic arthritis using an Koch's criteria. In Koch's criteria, the kid currently doesn't have the fever, only has the limp. So it scores 1. Scores 1 is 3% chances, so unlikely. A predisposing factor of a viral fever along with the limp is suggestive of a transient synovitis, fits in with the age group also. So it is a transient synovitis, not a septic arthritis. Another question in September 24 itself, this appeared in September 24. Another question in September 24 had appeared. Similar type. A 4 years old child brought to the emergency department with right-sided limb. There is no history of trauma. The kid has a fever since past few days. There are no previous history complaint. The child is developmentally appropriate. What is the most likely diagnosis? Here the Koch's score is 2. So the answer here is septic arthritis. Why? Because has fever since last few days. That means currently also having the fever. Along with it, there is a limp. Score becomes 2. This is a difficult question. I do agree. It appeared in September 24. It was a very difficult question, but you can always rule out. You can use logical answers and rule it out here. It's a 6 days old baby brought by emergency department by the mother who reports that the baby has not been tolerating feeds for past 2 days. During her pregnancy, the mother had a fatty liver. So this mother had a fatty liver during the pregnancy. Important point. The baby was born full term via normal vaginal delivery. In the emergency department, the child is found to be hypoglycemic. Correction is been administered. Laboratory investigation shows these are the parameters what you're showing on the laboratory investigations. Because hypoglycemia is corrected, so it has improved here. So what we are having, low BM the kid is having. The kid is having an metabolic acidosis because bicarb is on the lower side, pH is on the lower side, suggesting of a metabolic acidosis. Along with mom had fatty liver in her pregnancy. During her pregnancy, mom had fatty liver. Keeping on this point, each one of us, let's rule it out. Insulinoma. Insulinoma is basically a tumor which produces large amount of insulin as the name suggests. If insulin is produced in large amount, then hypoglycemia, yes, likelihood, but ketones will not increase. Ketones are seen when insulin is absent as you see in a TKA. So unlikely to be an insulinoma. Similarly, type 1 diabetes mellitus. In type 1 diabetes mellitus, sugar level should be on the higher side, not an hypoglycemia. I can rule out. Congenital heart diseases will not produce high ketone levels, what you're seeing here. They usually present with some breathing difficulties, some cyanosis, a murmur. That is the classical presentation. This is not a classical presentation. So you can rule it out, and congenital heart disease also. Now we are left with inborn error of metabolism and neonatal sepsis. Neonatal sepsis can have this kind of picture. Okay, but remember that whenever there is an sepsis, a severe infection is present. What happens? Stress hormones are released. One of the stress hormones is cortisol. Cortisol is nothing but a steroids which increases the BM. Very rarely during a sepsis, we see an hypoglycemia only when the liver is involved because of glucogenesis and glucogenolysis. Gluconeogenesis and glycolysis cannot happen. It happens only in the liver. It cannot happen if liver is affected. That's when you see hypoglycemia. This happens in mods, multi-system, multi-organ failure is present because of the sepsis. Can you see? Rare entity. Usually it is an hyperglycemia what you see because of sepsis. If you remember from our endocrinology chapter, sepsis, we said it can cause, sepsis is one of the predisposing factors for decay. So right answer here is inborn error of metabolism. Okay, a child born to a mother with an acute fatty liver of pregnancy usually is suggestive of an inborn error of metabolism because it is specifically related to fatty acid oxidation disorder. So it is a fatty acid oxidation disorder, which is an inborn error of metabolism. That's why mother had a fatty liver during her pregnancy. This is classical history of an inborn error of metabolism. Difficult question, I do agree, but you can always rule out in this manner, which appeared in the last stat. A 3 years old child is brought to the MS department by an ambulance accompanied by the parents. They report that the child has been experiencing difficulty in breathing along with the cough. On examination, the following observations are noted. Saturations are on the lower side. There is some amount of tachycardia is there. Right lower zone air entry is reduced. And the right upper quadrant abdominal pain is present. What is the most likely diagnosis? Right side you can see there is a consolidation. Whenever there is a consolidation, you can have pain in the right upper quadrant also, and there is a reduced air entry here in the right lower zone. It is all suggestive of an infection. Consolidation is nothing but pneumonia. It is a pneumonia. Bronchiolitis is usually seen in less than 1 year. Asthma, 5 years, we usually start labeling them. PFT is required, and asthma is bilateral disorder, and usually consolidation is not seen. Easy to rule out. Croup against stridor, it is upper respiratory tract. Bacterial tracheitis, or sorry, tracheal bronchitis, again, they present with copious amount of cough and copious amount of sputum. Unlikely they have an consolidation, which is highly suggestive of a pneumonia. They're asking maintenance fluid infusion for an 15 years age, and they have given in hours. When they have given in hours, first 10 kgs, we take it as 4. Next 10 kgs, that is 5 kgs I'm taking because it is 15 kgs, is taken as 2. For 4, it becomes 40. For next 5 kgs, it becomes 10, if I'm not wrong. So it becomes 50. So 50 ml per hour is the right answer, what you're having here. You're suspecting a life-threatening croup in this patient. Most appropriate step in managing this patient, they are asking. Whenever there is a life-threatening kit, what we'll be doing? Saturations on the lower side. First step is give oxygen. Okay, before going to the option itself, you remember first step is oxygen. Second step, I'll be involving the ENT, pediatrics, and the anesthetics I'll be involving. The third step where I'll be giving adrenaline nap. So out of all this, following each one of this, take the child from the mother's lap to the registration room. Do not ever take the child from the mother's lap. A distress can result in a respiratory arrest. This is absolutely no, no. Immediate ENT and pediatric referral, yes. Ask mother to wait. No, this is a life-threatening group. You need to immediately intervene. Nebulize the kid with adrenaline. That is the third step, not the second step. Give oral dexamethasone. You wait till the anesthetic team comes and you give oral anesthetic at that point of time. Again, no, no. So the right answer is immediate ENT and pediatric referral. A worried mother brings a 6-month-old child to the MS department, reporting that the baby suddenly turned pale and was fully recovered by the time of the arrival. There has been no similar incidents in the past. Baby has born at 37 weeks of gestation. On examination, the child is active and vitals are completely stable. What is the high risk for Brewy? They are asking. Age of 6 weeks. It should be at least 2 months, the age to call it as in lower risk, more than 2 months. It's 6 weeks. It's an high risk. Rest of the following are not high risk. CPR given by untrained profession, it is. That's why it is not there. It should be by the trained profession. That's why we are not taking this as an high risk. Completely recovery is a definition. Sudden pallor is a definition. 37 weeks of gestation. No, that is not an high risk. It should be less than 32 weeks of more than 30, sorry, less than 32 weeks of gestation should be present to call it as a high risk. A 4 years old child is brought to the MS department by the mother who reports involuntary movements of the right upper limb lasting for 5 minutes. The child has had a fever for a couple of days, and the mother has been administering the paracetamol. They have consulted the GP who has indicated that it is likely and viral fever. The father had a history of verbal conversion during the childhood. What is the most appropriate management plan? First thing is this a febrile seizures? Yes, it is a febrile seizures because there is a history of fever which is present. Next thing you need to ask is it a simple febrile seizures or is it a complex febrile seizures? It is not in simple febrile seizures because in simple febrile seizures, we see generalized tonic-clonic seizures. Here, the patient is having only one limb. So, focal seizures is suggestive of an complex febrile seizures. Complex febrile seizures needs to be further evaluated, needs to be admitted. Pediatrician needs to be involved. So, the right diagnosis here is referred to the pediatrician. Right option here is referred to the pediatrician. You cannot discharge them. We never give prophylactic anti-epileptics in UK. Either it's adult or a pediatric age group. That's why we do not give levetiracetam. Send cultures, nothing suggestive of an infection here. Observe in ED. You need to further evaluate. Even an MRI scan, EEG might be required. So you need to involve the pediatricians. So the right answer here is refer to the pediatricians as it is a complex febrile seizures. It is not a simple febrile seizures. That ends today's class. Anyone has any doubts, you can ask me now.